Zambia Blog Talk Radio.
Welcome to ZBTR TV.
The goal is to unearth and document the Zambian narrative in the best way possible.
Catch us live every Saturday on Facebook and YouTube.
We broadcast every Saturday at 10 a.m. EST, 7 a.m. PT.
With a growing audience across the globe, we connect Zambians and share resources abroad.
Be part of our journey. Please don't forget to subscribe to our YouTube channel.
With a growing audience across the globe, we connect Zambians and share resources abroad.
The ZBTR TV show.
Did you know? Less than 10% of our viewers are subscribed. Don't miss out. Be part of the community. Mark your calendars. Every Saturday, 9 a.m. Central Standard Time and 10 a.m. Eastern Standard Time. Flow live.
Welcome to the show.
Indeed, welcome to the show. It is Saturday, November 29th. So November has just gone like that. Time is really flying. Welcome to the show. We want to welcome everybody joining us. Tell a friend that BTR is live. We are on social media, Facebook, Twitter, which is X now, and YouTube, ZBTR TV. Do tell a friend that ZBTR is live. Today, we are going to have a conversation with our colleagues from the Global GA, what do you call it? GAZHP? Is that what it is, Yareka?
Yes.
Global Alliance. Global Alliance of Zambia Healthcare Professionals is continuing their discussions on issues to do with mental health. And Yareka is not a stranger to everybody. Good morning, Yareka. Welcome. Tell us what's happening today.
Good morning, and thank you for having us again on the show. Today we're talking about substance use diseases, substance use disorders. This is just a continuation from where we left. A few weeks ago, we were talking about mental health, and most of this is related. So we decided to pick up and discuss SUD, focus on SUD on this call. So we have a guest from Ministry of Health, and we also have some of my colleagues from Gazhp.
Okay, so I can see we have, Stalun. All right, so the first one is, he seems to be having that Zambian challenge. All right, let's introduce our guests.
Good morning again. So I think I'll have her introduce herself. This is Biemba from Chainama Hospital. She's also part of the Gazhp board. So please go ahead and introduce yourself.
Good evening from Zambia. Good morning to you. As introduced, my name is Biemba Maliti. I'm Chief Nursing Officer Psychiatry, working from Chainama Hills College Hospital. My interactions with Yareka go a few years back. I'm glad to be on this conversation and looking forward to hearing what our ministry has on the table regards mental health and particularly substance use disorders. Thank you.
Okay, Gabriel. Mr. Lungu. Okay, he's still having his challenges. Maybe we can begin with our with our lady here. She can. Mr. Lungu seems to be having challenges. He keeps dropping and coming and going, coming and going. I don't know what's going on with his connection.
Yeah. So I think maybe we can just, as we wait for Mr. Lungu to join us, we can just learn a little bit more on what Biemba's doing. Just 1 second. I'm sorry. My battery seems to be going away.
So, all right.
Yes. My apologies. So I was just wondering, maybe Biemba can give us a little bit more background on what she is doing at Chainama Hospital, how that ties into mental health or ties into SUD, so that we can, just learn a little bit more and pick it up when Mr. Gabriel joins the call.
Okay, so thank you very much, Erica. Thank you, Nathan. So I'm Chief Nursing Officer Psychiatry, meaning I'm Head of Department for Nursing Services. I moved over to Chainama early this year. So I'm basically responsible for nursing management of all the patients that come into the hospital, whether these are just being seen on an outpatient basis from the filter clinic or inpatient unit. So this covers the whole spectrum of psychiatry, general psychiatry, talking about bipolar mood disorder, talking about dementia, talking about schizophrenia, and then, of course, substance use. So for substance use, we have a unit, and we have 2 wards. One is a male ward, what we call E ward, which can have up to about 50 patients, anything between 35 and 50. And most of these tend to be pretty young, most of them below the age of 50. And then the females are in 1 ward. There's only 1 female ward for both those with substance use disorders and also those with general psychiatric conditions. And then, of course, there are those being seen by the outpatients department. That is our filter clinic. And then this is in close conjunction with also the Department of Clinical Psychology. As you know, psychotherapy is a huge part of trying to rehabilitate somebody after the acute stage of detoxification is over. Okay. So there's a workforce of about 150 nurses. Wow. And about half of these are actually mental health nurses, and then half of them are registered nurses. That's actually not a lot of nurses when you look at the demand for care, because we have roughly maybe about 150 patients admitted. Okay. That is minus the ones for forensic psychiatry. When you add the ones for forensic psychiatry, you're talking about nearly 300 patients sometimes. So yeah, the workload is there, but we also have those we call ward assistants. These are like your care assistants that also help with the care. And it's important to note that we only have 7 psychiatrists, the whole country. And most of these are stationed at our hospital. So you can imagine that 7, workload, the whole plus country, the filter clinic, 7 psychiatrists.
Interesting. So how yes, you mentioned that
psychiatry still has ways to go.
Yeah. So you said 150 nurses, half are psychiatric nurses and the others are registered nurses. How is the collaboration? How do the registered nurses find themselves in a psychiatric unit? Did you hear what I said?
So your registered mental health nurses are the specialists who are trained in mental health nursing. So they provide the specialized care and also supervision and mentorship for the registered nurses. As a registered nurse, your training covers every aspect of healthcare. So all of us went through a psychiatry rotation during our general nurse training. So they have some orientation to psychiatry. And when nurses come to Kainama, they go through a 7-week rotation through all the units, plus a 5-day didactic course to introduce them to the common psychiatric conditions and how to use clinical tools and also psychiatric emergencies.
Okay. That is excellent. So in what I would like to sort of get an understanding of something is that does every hospital have an aspect of psychiatric nurses in them?
No, unfortunately. But we keep on advocating and hoping that we can get to a place where every hospital, the way they have a social worker, they should actually at a minimum have a psychosocial counselor, a mental health nurse, and a psychologist. So there are a few big hospitals like Levi Mwanawasa University Teaching Hospital does have a psychiatry unit, and also Ndola Teaching Hospital has a mental health unit, and then Kitwe Teaching Hospital also has some psychiatric nurses and some clinical officers. There's what you call clinical officer psychiatry. Okay. So these ones actually are the stopgap between having an actual psychiatrist, and they're the ones who provide the primary health care level. I think first line interventions and first line assessment for people having a mental health disorder. So they are a very invaluable part of the system.
Yeah, the reason I'm asking that is because I think it's important for people to understand that when whichever hospital they go to, if there's that component of a psychiatric where they can get Mr. Lungu. Okay, a lot of technical issues today. So
yeah. Anyway, our internet leaves a lot to be desired with the power cuts and all, so it's expected.
Yeah, it's expected with the power cuts and everything, and we hope we can make this work. Yeah, the reason I asked that question is because I think it's important for people to understand that if they go to hospital and their case is of more of a psychiatric situation, if they are based in Kalulushi, Cherenge, and all those places.
Okay.
Yeah, so basically, go ahead.
So what happens is, like I said, clinical officers, nurses, doctors, they all do a psychiatry rotation. So when a person presents to a healthcare facility at whatever level, if it's a hospital, they'll have a casualty or OPD department, and people there are able to determine signs and symptoms of distress.
Yes.
And then also Mr. Lungu and the team from MOH have been going around the country training primary health care personnel who are not specialized in how to deal with mental health conditions. And then, of course, once they do the initial intervention, then they're able to refer this person to a more specialized place if they do not have the facility to be able to manage this condition. We have places across this country who are managing mental health conditions that are not complicated. They even have the drugs. So someone in Katete will not have to come to Lusaka, for instance. They could get their first line drugs from there. Somebody in Livingston could be taken care of from there. Somebody in Northwestern Province might end up going to Solwezi General because there's a mental health officer there. But most districts now have a mental health officer. So you find that even in my home district of Kabompo, there is a young lady at the district hospital who is actually able to provide mental health services that are not complex. Okay. So one of the things the ministry is doing is decentralizing mental health care. Yes.
That's interesting.
And if you
That's
notice,
very interesting.
Yeah, if you noticed at the UN General Assembly this year, mental health was one of the key things that was mentioned. And this is about trying to make sure that this service is part of the primary healthcare package, part of primary healthcare services, in a bid to ensure that there's universal access for everybody, even to mental health services. I can see Gabriel is here, so he can expand more on what I'm saying about decentralizing mental health services. He's been trotting all around this country doing a fantastic job of training teams.
Okay, Mr. Lungu, welcome. Could you tell us overview before you respond to what she has shared? What does your work entail?
Thank you so much, and my apologies again due to technical efforts to join on time. Yeah, so I'm Lungu Gabriel. I'm the mental health officer managing the mental health program at Ministry of Health. And my job is basically to coordinate mental health services in the country to ensure that they are available at lowest point of care. People have easy access to mental health services, not only at tertiary level. And also we are doing health promotion so that we ensure people have at least a balanced well-being. They are aware of their attributes of keeping themselves holistically well. And also our job is also to foster the preventive strategies by mitigating the risk factors to mental illnesses. So basically, we are responsible for putting in place some strategies that would help us achieve our agenda of prioritizing mental health and, of course, preventing mental illnesses from occurring. And that looks into the aspect of the adequacy of infrastructure, commodities and supplies, of course, human resource, and other supportive resources which are needed for people to effectively deliver the mental services to the general public.
Okay. So, yeah, excellent. That's a huge response. Now, Valungu, just your head is cut. Just
let me elevate my camera a bit.
Yeah, try to make some adjustments so that we can see you properly. Okay, that's better. That's better right there. So just try to give us some insight and details about what your colleague has said about, I like the phrase she's using, decentralizing mental health.
Sure.
Let's talk about that.
Well, yes, she's very much right. I think that's the agenda that we want. I think Zambia, time immemorial, has known to provide mental health services basically at tertiary level. That is, I think, Chainama. When we talk of mental health services in the country, Chainama doesn't miss. I think it becomes the first referral point of mental health services. And as such, it has been identified that only concentrating at the tertiary level is more like just waiting for cases to come and overwhelming the only psychiatric institution that we have. And what are the strategies to decongest, for example, Chainama, and at least lessen the burden of Chainama, is to provide the services or to centralize, to take the services to the lower structures, to the subnational levels, that is provincial, district, and of course at community level. And I think that has been our mandate, to ensure that each province has active psychiatric units and of course mental spaces where people from those provinces can access the services without crossing maybe boundaries into another province. So that's what we have been making. And in addition to that, we want also within the provinces to capacity build the districts themselves, so that each district hospital has that capacity of ensuring that mental services are provided within the district. And this also adds to lessening the burden of maybe caregivers who might have maybe mental patients, who the cost of transferring or moving with a patient from one point to another is quite costly, and we want that too. And of course, what we have seen, I think we have been, as I said, we have been only treating, and yet we have not been screening and of course detecting cases early. And that again, we have seen that it's a very, very big gap. And we are really taking the services to community level, so that we capacity build community-based volunteers, the community themselves, the families, so that they are able to identify early when someone is presenting with a mental a symptom, so that they can quickly go to the hospital, so that we prevent chronic conditions. Because our philosophy, I think my philosophy, which I've held, I think developing a mental condition is more like developing a disability. So for me, I'm not really a fan of seeing someone going to that extent of developing a mental conditions, because it is a sign that it has taken so long for those symptoms to manifest. So going community way, and of course strengthening and integrating mental health into primary healthcare is the way to go, so that cases are managed at community and at primary healthcare level. And that itself is also going to receive this acceptability, and of course lessen the stigma which people have. Because again, that's a big barrier that you have seen as well.
Yeah. Are the other than Chainama Hospital, have systems been established or put in place where, other than Chainama, where they can admit a mental health patient? Like what's her name? She mentioned the Ndola Kitwe Teaching Training Hospital. And are they able, because you've been going around trying to equip, train mental health, the healthcare providers to be equipped to handle mental health, are they able to admit a mental health patient?
Yes. I think even in history, before we talk of Chainama has been a tertiary hospital, but it has also been supported by about 12 mental health annexes in the provinces, which have some admission spaces. I think of about others 12, others 24. Ndola should have about 65 bed capacity. Choma, that is in southern province. So each province has the bed bed cities. So at least in a province, there's one hospital that is admitting, with the two now, which is the Eastern Province and Muchinga, having at least the modern prototype of the structures with about 22 bed capacities. So they're able to admit there. So yes, we have now admission spaces in all the provinces, except Northwestern for now, because I think that's where the one structure was built, but it couldn't fit for psychiatric rehabilitation. So that's where we are trying to establish so that we cut supply of patients, because they are referring patients to Ndola Central Hospital, which is the Copper Belt. So I think that's the only province, but it had also the space to admit patients. So yes, I do admit that we have admission spaces in the provinces now.
Okay. Biemba, what feedback or collaboration goes on between the main hospital in Lusaka, Chainama, meaning with the other centers around the nation? What collaboration goes on? And are you able to monitor, in quotes and quotes, what's going on in the other centers around the nation? Biemba.
Yes, there is. We have a mental health national coordinator, Dr. Francisca Bwaria. So she coordinates works at that level. Then also our head clinical care, Dr. Tandiwe Tembo, plus other members of the healthcare team, they usually do technical support visits. So when you get the data coming from out there and you notice some maybe hiccups or bottlenecks, then people go out. And like early this year in January, a team of nurses actually went to Ndola Teaching Hospital, the psychiatric unit, because we recently had new mental health nursing protocols launched. So a team went there to strengthen. So we do have teams that go, you'll have psychiatrists, clinical officers, and they will go to a particular facility, look at the treatment protocols that are being used, go through the files, have discussions with the team on the ground, and sometimes actually review cases with them in order to strengthen their work. And then also there is support for drugs. So these facilities are able to reach out to Chainama and get some of the medications that they cannot get for their patients, instead of having a whole patient travel all the way to Lusaka. Of course, because of human resource constraints, this is not as frequent as it should be. But I think with the lessons from COVID, I think telehealth and telementoring also could help strengthen patient care and quality issues out there, including strengthening availability of supplies required to ensure that patients are taken care of well. But there is technical support that goes on periodically throughout the year.
Are you able to talk about these new protocols that you're just mentioning? What are they? What did that entail?
So this is mental health nursing protocols, where you have different SOPs that help you take care of a person with mental health disorders to a certain standard. So they've been compiled into a manual or a book, and these are now available. So recently, a week ago, I was in Kabwe at a chief nursing officer's meeting, And these were also distributed so that all these 20 colleagues from different parts of the country can take these to be able to ensure that, remember the question you asked about if somebody presents with signs and symptoms of mental distress, what happens? So these are the tools that we're ensuring that colleagues out there have access to, so that they know how to assess a patient, they know how to manage a patient according to the standardized way of doing it. So it's a really huge step and milestone to ensure that everybody across, even if you're not a mental health specialist, at least you know what to do. It's a step-by-step guide.
Okay.
Can I just have a quick question for Mr. Lungu? I know you mentioned that there's about 65 bed capacity in Dola. What's the bed capacity at Chainama or in Lusaka?
For Chainama, it was initially designed to accommodate about 210 patients. So that's the bed capacity for Chainama. And of course, we have also the correctional side that was supposed to house close to about 100. But now, because of the dynamism in terms of bringing other inmates, I think the population has increased. So in total, in the initial inception of psychiatric genesis, we are supposed to have about 500 bed capacity countrywide. Chainama taking a portion of 210, with also other annexes in the provinces adding to that gap, which is about is it 290? To sum up to 500.
500.
But with the expansion now, with the addition of other two psychiatric units of about 22 bed capacity each, that is in Muchinga and the Eastern Province, of course, in Petauke, we are slowly adding those numbers. They are adding to that. So we are likely to have, at least the number is increasing in terms of bed capacity. But we still have a very big deficit because patients' inflow is high and the population is increasing. Definitely, that's an area where we need to expand the admission space.
So what I've seen here in the US, because I work in the same industry, I work for an organization that provides services for substance use treatment as well as mental health. So it's a nonprofit and it's licensed by the state. So the strategy that I guess the state has taken is opening up beds and allowing nonprofit organization to manage those beds rather than the states themselves. They have their own infrastructure, but I guess they realized that they didn't have enough bed capacity. So they work very closely with nonprofits. Is that the government, the Zambian government or the Ministry of Health, are they also opening up opportunities for other providers, nonprofits, to work with you to support what you're doing and to increase the bed capacity? Because I feel like 500 beds for the whole country might not be sufficient. So what other strategies is the Ministry of Health implementing to increase access to treatment?
Well, yeah, I like the model that is being, I think, implemented in the US, which is really good. Of course, which may be a little bit different to our landscape here in Zambia. Most of the NGOs, I think, that have come through to support us, they have really been investing in other areas of the health sector. Maybe majority of them are into health promotion. Others are maybe into just other supportive services other than in that space where they would want to invest in increasing the bed capacity. I think the only area, I think it has always been the state commitment to increase the bed capacity, particularly in the substance use. Our President, His Excellency, Mr. Hakainde Hichilema, I think in 2022 during the drug day, he committed that we need to construct the National Rehab Center. Of course, that is the state commitment, meaning that we may have one expansion in terms of bed space in the rehab sector. And that might solely be managed by the state, because usually I think Drug Enforcement Commission and the Minister of Health work hand in hand to look in that area. And also other line ministries, I think they are also the ones I've seen managing other bed spaces with their areas of interest. For example, Minister of Community Development, they are managing some homes for the aged, for the aged, of which I think material aftercare, which Chainama also is aligned to, manages that, and then others are in Copper Belt and so on. So I think it's really a model maybe that we can try to really sell with our NGOs if they can really buy in, because majority of them, I think they are just investing in the low budget, I think, areas other than infrastructure or managing such huge investment. I think it's a gap that we have, and majority of maybe those who have gone to establish other maybe health service mainly are on the profit making side, and you know where the limitation of the state, because when, for example, want to go into MOU with an organization that charges, meaning that maybe the state has to take some of the maybe the insurance in terms of insurance covers for those patients who might be referred into that. So there are those policy direction and of course frameworks that needs to be put in place.
I think you bring up a good point as far as funding and sustainability. What we've seen also is a combination of government support and then nonprofits. When I say nonprofits, I'm not even looking at outside nonprofits. It could be local, community-based organizations, just families that have come together. Maybe they're affected by SUD and they want to give back in one or the other. It doesn't have to be hundreds of beds. It could be 5 beds, because that's also another model that the state here has taken. They have different models. They have like 7 beds model. You can have 15 bed, especially with mental health. They don't really have big institutions. They prefer nonprofits have maybe 15 beds maximum. Then it's easier for you to manage those 15 beds. For SUD, it's different. It might be like one of our facility, it has almost 200 bed capacity, just one facility, and then the others are smaller, 60, 65, 96, and so forth. So I think working with the community, taking it back to them, because these issues are affecting the community, and seeing those that are interested in setting up small bed capacity organizations that they can bring in patients, but then they have to be licensed by the Ministry of Health. So I don't know whether you already have this infrastructure set up where other hospitals or clinics, even if it's their private, are licensed by the Ministry of Health. Is there such a process if someone was to set up a clinic for substance use or for mental health? Do they get licensed under the ministry?
I think we have other I think bodies or institutions mandated to that. I think HPCZ, that's the Health Professions Council of Zambia, and also Nursing and Midwifery Council of Zambia also comes into play, and of course the Minister of Local Government through the council also, they have to clear such. So there are quite a number of bodies that needs to accredit such an institution. But of course, with a recommendation coming from ministry, all those who are venturing into healthcare investment, they come through Ministry of Health to seek that recommendations for them to establish such facilities. But of course, just to maintain that professional code of conduct, just to regulate the operations and so on, so that they are within the realm of professionalism, other parastatals come into play, such as HPZ, NMCZ, and even we have counseling council, of course, in case counselors are involved. We have a psychologist state of Zambia, all those bodies who are managing those professions, who might run those institutions.
Do you have, to follow up on that question, are you able to give us an idea of how many institutions are existing which are operating in those lines, offering those services?
You mean like who are just for licensing purposes, or
no, who are actually organizations who have been given the licensing and authorization to provide that service?
I think there are about I should say 4.
Okay, in the whole nation.
Yeah, I think those are the other ones who are managing those the licensing, because maybe CNO Malit can add to that. But on the professional regulation, I think NMCZ, because again, it depends with we have biomedical associations again with all these areas, but the mother bodies of regulation usually is SPZ, NMCZ, and of course, it might go maybe to community development that usually registers again NGOs, and of course, Ministry of Health itself.
Okay,
yeah,
that's good. I have.
Maybe let me just add to the conversation on privately run mental health facilities.
Yes.
So there are some that mostly focus on rehab services and counseling. I think like Great North Road runs a quite well-known rehabilitation facility. And then, but roughly there are not too many, but there are a number, especially for that we're talking about substance use. So you have people running rehabilitation centers. And of course, like Gabriel did mention, these have to get licensing and accreditation from the Health Professions Council of Zambia. And then now the only thing is mental health, I think, on our health insurance still hasn't got very great coverage, because where you have good coverage, I think obviously there has to be advocacy. I'm coming from a background of oncology. Even for cancer care, it took engagement for even radiotherapy and chemo to be covered by NEMA. So even for mental health, we're going that route. And when you have more coverage for certain conditions, you have more players, because then it's beneficial for them. They can make claims because psychotropic drugs and psychotherapy tends to be quite pricey. So value for money and things like that. But I think once NEMA extends coverage for more services under mental health, you can see more players. The government is encouraging PPP, public-private partnerships. So there are a lot of private hospitals in Zambia. But, you know,
mental health,
really,
not
hospital. Mental health. I mean private hospitals in general. Like with cancer, initially there was just Cancer Diseases Hospital. Now you have a lot of hospitals offering chemo because there's the coverage under NEMA. So we're hoping that with greater investment in mental health, it will encourage people to actually venture into, like Yareka was talking about, non-profits, but in our setup, it would be private individuals or organizations setting up facilities. Like for substance use, Chinama does acute care for detox. But what we lack is the stopgap. Once you're detoxified, the rehabilitation, then back into community integration, that step is not really well defined. So there are some who offer the service, but then people must pay. And you know, the average Zambian, you know, cannot afford some of these services.
Yes.
Exactly. So really, we need to invest in rehabilitation services. Acute care, we're doing quite well, although coverage is low, looking at the bed space, but rehabilitation and strengthening community mental health is the way to go, because stigma is a huge elephant in our society, unfortunately.
And then just to add to that, just even here, it's the same thing. There's so many gaps in the whole continuum of care, starting with crisis. So someone comes in, some programs just have 23-hour crisis centers. So a patient is stabilized, and then after that, they're referred maybe to a five-day program. So they're going to be there for 5 days. And then while they're there for 5 days, they're looking for something a little bit more extended, maybe 28 days. So there's some programs just do 28 days. And then some go up to 9 months. So they start with stabilization, 28 days. Then they go to rehabilitation for another 4 months. And then they go to reintegration, which is maybe another 3 months. So a patient can be in the program for almost a year. Which costs a lot of money. So if government is not involved in subsidizing that, it's very difficult to manage such programs. And I think, yeah, like you mentioned, if we do have the acute care, maybe the next step would be, how do we have even these 5-day programs, and then, just increase with time, and also continue lobbying, because it's very, government has to subsidize most of it. Even here, the model is almost 95% is Medicaid in New York, and Medicaid is a government program. So we struggle to get commercial. Commercial is less than 5%. So I see the same thing happening in Zambia, that we may have to do a lot of lobbying, talking to government to increase the budget, and then building up from there.
Okay, let's zero in into something here. You can both respond to this question. What prevention efforts are in place in schools? Schools are very critical places, and communities, and what challenges remain? I'd like you both to contribute to this question.
Who start first?
Gabriel, you can start. You're more out there than I am. I spend 90% of my time at the hospital, so he will talk a little bit about it, and then I will provide some examples of how we also get involved.
Okay, Gabriel, go ahead. What programs are in place for schools?
Yes. So for schools, I should mention here that I work very much close with the adolescent unit and Ministry of Health, which we again works very close with the school health programs. And we have also the health promotion department that just focuses on school health. And mental health is a key component in the school health program. We have done quite a lot in terms of SBCC strengthening in schools.
What are those terminologies?
Oh, that is social and behavioral change and communication. Yes, we have done quite a lot of social behavioral change. So in schools, we have taken quite a lot of more like awareness programs, just sensitizing the learners. So we have some IC materials that have been developed on various topics, just to sensitize the learners. And also, Ministry of Education has taken it establishment of the counseling and guidance unit in schools. That is, I think, the gate to which we, Ministry of Health and other institutions and partners who are interested in us, learners' welfare, are usually going through. And yeah, I think it's quite a lot. And there are some documents. We have counseling and guidance protocols that have been developed. We have developed also some IC materials, as I mentioned, and also just some materials for learning as the topics in schools.
Okay.
So I think those are things that we can.
Before Biemba responds, can you facilitate for us to talk to your colleague who does this at the Ministry of Health? The school.
Sure, we can.
Yeah, that would be good. Go ahead, Ms. BM.
Well, Nathan, I just had one more question as well, or comment. Can we change the terminologies, especially in the community, when they're talking about patients who have substance use disorders or diseases? Here we refer to them as diseases. All I hear now is a junkie. This is a junkie. This is a junkie. Can we change that in the community? Because I think it starts with us. It starts with families. It starts with outreach. In the past, I'm sure we heard a lot. We heard a lot of patients being referred to as addicts. We don't hear that anymore. They're patients. So is there anything being done to raise awareness that, families are the ones who take their children to the hospital? They're the ones who have to support the so-called junkies to recover, right? So they're the ones who are wearing the responsibility. So it starts in the home. And I hear everybody just say, that one's now a junkie. So what is being done to raise awareness?
Yeah, and as you rightly said it, I think it's one of the struggle that we have. And you understand that some of these terminologies are not really emerging from the enlightened populations. the terminologies that are being crafted at community level and within the communities themselves. And it just had to take someone who is well enlightened to go to the community and explain the impact of such terminologies. The Mental Health Act that we have, which is number 6 of 2019, tried to at least appeal the 1949 Disorders Act, SWATI. We have terminologies that really recognize a person first before the conditions or whatever label. So I think it's really a terminology. It's not the only one. There are quite a lot. Sometimes even in vernacular, there are terminologies that are really derogatory that we just sometimes use English to make them lighter. For example, calling someone, yes, as you said, a junkie, a mokomoko, one wire, such terminologies, they take away the identity of the person. So, yeah, I think we have a lot that requires not only the health sector, but the entire chain of one's development, because I think junkies, it refers to young people mainly. So if we can stimulate the entire chain of child development from an individual or families, communities, and of course, ministries and stakeholders who are involved in children's welfare, we should be developing someone who grows with a self-esteem, positive self-identity, other than wearing a jacket of a junkie. And I think that's one barrier I think we are really struggling with.
Yeah, a lot. Miss Biemba, your response to the school program thing.
Okay, so first of all, one thing I would say is UNICEF has come up with absolutely beautiful policy documents. Because even here in Zambia, UNICEF has actually got a chatbot targeting young people's mental health. So one of the things that they have done is there's a Helping Adolescents Thrive toolkit that has got strategies to promote and protect adolescent mental health and reduce self-harm and other risk behaviors. We have heard of children taking their own life, children getting into alcohol and substance abuse because they are stressed or because they are misguided. So there is also the guidelines that were introduced that actually target learners in schools. So this one is based on about 5 pillars. They call them the 5 essential pillars for mental health support in schools. And this is a policy document that governments are being encouraged to own and then scale down and implement. So this one looks at an enabling learning environment, developing a school-based mental health policy. And one thing I can give credit to Ministry of Education is that they have started the school health rooms. So for me, that's a start, because now every school is going to have what used to be called sick bays, but they're calling it a health room. So if that could also be broadened to encompass mental health, it would be great. So an enabling learning environment. The second pillar is access to early intervention. Most parents and guardians will bring their child when it's totally beyond redemption. When the child starts acting out, they start exhibiting behaviors that are not correct. Sometimes people think Chinama, there's stigma. I can't take my child to Chinama. So if we can have mental health access at primary health care level, like we have the adolescent health corners in the clinics, and these are beautiful spaces that provide sexual and reproductive health. So if they can be expanded to provide mental health support, people will feel safer and less stigmatized to take their child or guardian who is having issues that sometimes a parent is feeling inadequate to help with. And then also you have promoting teacher well-being. Usually government workers, I think, are like machines. I hate to use the word, but it's all about productivity and output, and nobody cares about how you're doing. So one of the other pillars that people must look at is, how is this teacher coping? Are they okay themselves? Because if the teacher is in a good state of mental health, they're not having challenges and issues, there'll be a better support for this child or young person. Because some of these children come from homes that have disintegrated, and their only safe space is the school.
So I just want to add to that. I want to add to that, what you mentioned about the health room, I attended a meeting a few weeks ago, and an organization was sharing the model that they have. So they have an online portal, and that online portal connects to a school, or just a school in the area. So whenever a kid is identified as, having some mental health issues, the school now notify this provider, which is a nonprofit in the community, to intervene, to support that child. And, of course, with the parents' consent. But there's already that connection with the school. It's a direct connection. So anything that the school sees, they immediately are able to refer to a provider. We also have the same program, but instead we have a counselor from our program going into the school once or twice a week to talk to kids who want to have a conversation with the counselor. So you can do it online, you can do it in person. You can have a counselor going into a local school and providing the kids. Yes. But I think I wanted to pivot, Nathan, to substance use, because today was really trying to focus on substance use. But I guess Mr. Lungu has dropped off.
Mr. Lungu has dropped off, and we should be winding down now.
Yes, because I wanted to find out if the Ministry of Health department that focuses on mental health is the same department that focuses on SUD.
Yes, it is, because we actually have what you call the alcohol policy.
Okay.
Yes, we have the national alcohol policy. I think I will share this document with you on the Gazhp platform. So, for example, just recently in August and September, there was a training actually for 70 professionals who were diverse in substance use. This was a US funded program. What you call universal treatment curriculum, then universal prevention curriculum, and community outreach. So some staff from Chinama were there. We had the clergy, we had counselors. I think there were some traditional leaders. So that one was championed by the Ministry of Health, and the training was intensive for 20 days, but broken in 2 groups of 10 days, 10 days, because the ministry and stakeholders have realized that alcohol and substance abuse really is a time bomb that has, I think, just about ticked off in front of our faces. What I'll do is I'll quickly share a few stats from our 2024 data, the patients that we saw, the top 10 causes of morbidity. Alcohol use disorder was 37% of our total patient attendance. This is at our filter clinic. We're not talking about the ones admitted. We're talking about the ones coming. So there were 1,351 males and 174 females. In 2023, that was 43.9%, about 2,000 in total. And then drug use disorder, in particular cannabis, accounted for 16%.
Wow.
And yes. And then, so you can imagine that if you add 37% and add 16%, you're talking about half of our patients are dealing with alcohol and substance use disorders. Half of our patients.
And I've been told that alcohol withdrawal is far much worse than other drug withdrawals.
Yes, it's actually one of our terrible emergencies. And if they're not brought in early enough, when they have delirium tremens, you actually lose the patient. Yeah. So we've actually had to, I had to arrange for a workshop for the nursing staff, and we did psychiatric emergencies, and dealing with DT was one of the things we had to teach the nurses, how to manage somebody who is in acute alcohol withdrawal, because their vital signs are all over the place and you have to stabilize this person. So you can see how huge a problem it is. And it is actually very great that the ministry, in collaboration with partners from the US, invested in this training. So it covered, like I said, 3 things: the universal treatment curriculum, so strengthening the ability of workers to deliver evidence-based care. So this targeted the doctors and the clinical officers And then you have the universal prevention curriculum, empowering educators and community leaders in being able to protect our youth from drug and alcohol abuse. And then the community-based approach, addressing the social and policy drivers that influence substance abuse, because we have this vicious cycle where somebody comes in, they do detox, you start rehab, they get back into the community, and they'll come back, you're back at zero. So we have this vicious cycle that we're hoping this training is actually going to address, and we'll begin to see some light at the end of the tunnel. But otherwise, the situation is quite dire. And it's our young people. You're talking about people below the age of 40.
Let's conclude this by asking this question. Obviously, the purpose of these conversations is to come up with some tangible, workable direction. How can diaspora professionals partner with what you are doing?
I think one of the things, obviously, first of all, is capacity building, because you heard the numbers of staff on the ground, and most of them have just done general psychiatry and general mental health. That's why I keep on saying this training that we had with 70 people trained, particularly targeting substance abuse, was great. So it would be nice if we're able to ensure that our psychiatrists, our nurses, our clinical psychologists and counselors can actually get immersed in how to deal with substance and alcohol abuse and rehabilitation, the whole 9 yards. Secondly, some of the drugs that are required for a detox, they're quite pricey and they're not on your essential drugs list for mental health. So if we're able to have partners come on board who could support drug supply for some of the drugs, you're talking about the methadone patches, the such things, I think it would be absolutely great. And helping us also, rehab centers. We need rehab centers. We need rehab centers like yesterday. And then also, like the surgeons have these camps, like for heart conditions, you'll have a team that will come from wherever, UK, Israel, and they'll have a camp for maybe heart defects. They'll have a camp for orthopedics. And the last time, I think there was that Orbis aeroplane that came for ophthalmology. It would be great to actually have mental health camps where experts come and spend maybe 2 weeks, not necessarily at Chainama, maybe 3 days in one place, 3 days in another place, and visit a few centers in the provinces so that people can be reassessed, people can be, and our team on the ground can have, what do you call that, knowledge transfer? So for me, that would be absolutely great, because then you are empowering us to improve care and to sustain what we're doing and amplify it. And then right now we're in the age of technology, digital health. So remote clinics with a specialist of cases that are really mind-boggling for our team. Like I have electroconvulsive therapy. We have the machine and all, but we don't have anybody who can provide that treatment. So our machine is like an elephant. So yeah, knowledge transfer, drug support, outreach camps with experts, I think that would be great.
Excellent. All right, Yereka, I think let's conclude it here. I don't know if you've got any final remarks before we wind up.
No, thank you. No, this has been great. This is again continuation of our conversations around mental health and substance use. The last meeting we had, we focused a lot on mental health. Even this meeting today was mostly mental health, but we transitioned to SUD. So I'm hoping that the next conversation will pick it up. We do want to focus on what type of treatment that we have available, where patients can go. We also want to focus on the prevention, right? What kind of outreach activities, and then obviously like what Nathan has mentioned, how we can get involved, how can we support capacity building. That's a big problem everywhere. We have a challenge hiring providers even here. So we probably have to talk about training. How do we train our local providers so that they can provide the support that the patients need?
Excellent.
Thank you so much, Ms. Biemba. And Mr. Lungu has dropped off. And thank you for listening.
Yeah, I'm sure he can still hear us. It's in the background, but it doesn't have whatever. Thank you, Obiemba. Gabriel.
Thank you very much. I had a wonderful time.
Gabriel, can you work on that? Yeah, can you work on getting your colleague on the school staff so that we can see? I'm interested in doing a program on that, and let's see what happens. And maybe we can have Joseph, who's in the background. I don't know what's happening with the technical issues. So that we can, we can pick up the conversation from there, and then you can never have too much conversation on this. It's very necessary.
We learn something every day.
Thank you, everybody. Have a great weekend. So a special announcement, please join me on Wednesday. I'm having a special feature with Mrs. Beauty Katebe, the chairperson for Oasis Forum. We're going to be talking about what's going on in the country right now concerning the constitution and all these things. Thank you, everybody. Have a great weekend, and I will see
Zambia Blog Talk Radio.